Hi, this is Tim from ChiroUp, and we know that pain over the sacroiliac joint can come from a number of different sources. Historically, the data has said that discomfort arises from the sacroiliac joint in about 14 to 22% of cases. But a new article in Clinical Spine Surgery said that it may not be that high. Only 3% of discomfort over the sacroiliac joint actually comes from that joint. 90% of pain over the joint is referred from the lumbar spine. 4% comes from the hip, and 3% were unidentified sources. Now, this study was only 124 patients, but I think that it's very relevant because it points to areas and issues that we need to be concerned about. The blog that accompanies this video talks about the patient's history and findings that we may see related to different sources of lumbar referral. This video is going to cover the orthopedic evaluation and the systems that we can use to define where's that pain coming from. So let's start with the sacroiliac joint. The patient's lying on their back. The Laslett criteria said that there are 4 tests that we can use to identify sacroiliac joint pain. The first one is sacroiliac distraction, putting our hand on the patient's ASIS and scissoring that apart. The second one is the thigh thrust, where we bring the patient's knee into 90-90 at their hip and apply an axial compression through the femur, shearing the sacroiliac joint and a little bit of the hip as well. Then we have the patient roll onto their side, and we're going to perform a sacroiliac compression, where we're applying a straight down force through the ilium, and finally they go onto their stomach, and we can perform the sacral thrust, where we're applying a pressure over the patient's sacrum. When 2 of those 4 Laslett maneuvers are positive, we can be pretty confident the sacroiliac joint is the culprit. Now, in the lumbar spine, 90% of pain over the sacroiliac joint actually comes from the lumbar spine. In fact, a lot of clinicians use the rule that pain over the sacroiliac joint is from the lumbar spine until we prove otherwise. There are really 2 mechanisms by which this happens. Number 1 is a sclerotogenous referral, where an irritated disc or facet refers sclerotogenous pain to the sacroiliac joint in much the same way a heart attack would refer to a face or a jaw. The second way this happens is through radicular pain. And for the radicular component of this, the way that we're going to test that is through flexion or extension bias testing. We want to know which one does the patient like, and can we centralize that symptom, because although it's only going to the sacroiliac joint, it's still a radiculopathy. We're used to seeing it shoot potentially further, but if it's radicular pain, let's see if it changes. So the way that we're going to assess those is first we're going to get the patient's history to find out, is it likely to be provoked by flexion or extension. Patients who like flexion will typically like sitting. Patients who like extension, those are extension biased patients, they like standing and walking, so their pain improves. 80% of discogenic pain is going to be an extension biased pain. So if the patient's history confers with that, we'll start an extension. That's going to be having the patient lie flat on their stomach. Then we're going to have that patient prop up into a sphinx position onto their elbows like they're watching TV. And then finally from there, they're going to come up into a full extension. And then they can do that repeatedly, and we can apply some overpressure over the top of that. If the patient's pain centralizes, meaning comes out of the sacroiliac joint and back to the lumbar spine, even if it's a little worse than the lumbar spine, we can suspect that that was lumbar pain that was extension biased, referring to the sacroiliac joint. Now, if that makes their pain worse, or it centralizes or doesn't change, then we can test inflection. And for that, we have the patient flip onto their back and perform a knee to chest with a little bit of overpressure. So they pull both knees up to their chest, and then they can go ahead and apply a little extra pressure, and we can apply some overpressure too that is needed. We can do that for 10 repetitions and see, does the pain centralize, which we're looking for, or does it peripheralize, which we'd want to stop right away. That can also be done in a seated position by having the patient to grasp their legs and pull themselves forward. Now, this sclerotogenous referral in the lumbar spine, we'll typically see that there's more pain when we apply a PA shear to the lumbar spine as opposed to the Fortin finger test over the sacroiliac joint. And finally, when it comes to the hip, this is one that tricks us up quite a bit. That hip pain refers to the sacroiliac joint and to the back, and sometimes we miss it. One classic finding of hip pathology is the C sign, meaning that the patient makes a C and they put it over the top of just above their trochanter, going into the groin crease. Anytime that we see a patient who has groin crease pain, we're very suspicious of the hip. And then we can run through a range of motion too with the patient lying on their back. We can bring their hip up into 90-90, and we can again do a Fadir test where we take it into internal rotation, or a Faber test into external rotation. A lot of times patients with hip pathology, especially degeneration, don't have much internal rotation. When that's limited, we're thinking that the hip may be involved in that process. And then the final thing that we're going to think about is the 4% of hip pain that is unclassified, meaning that it wasn't mechanical. So we're looking at possible visceral referral, and the genitourinary system would be a common culprit there. We're also looking at the potential for inflammatory pain. And so rather than mechanical, maybe we're looking at an inflammatory arthropathy. And there are 4 characteristics that we want to look for. Number 1 is that morning stiffness lasts longer than 30 minutes for inflammatory pain. Number 2 is that these patients like light activity, they feel better, and they feel worse when they're resting, which leads right into number 3, that they often have pain that awakens them at night, especially the second half of the night when it's inflammatory pain. And finally, they'll have pain that alternates from one buttock to the other. So if it's switching sides in the sacroiliac joint, maybe a degenerative spondylolisthesis, but more than likely there's some inflammatory component to that. I hope that this information was helpful to allow you to better identify where the cause of that patient's sacroiliac discomfort is, recognizing it may not always be the sacroiliac joint. Hope you enjoy the accompanying blog, and we'll look forward to chatting again later. Thanks for watching.